All right. Today's theme is sickle cell disease, current medical and mental treatments. I am Tamia Martin, and I am a licensed physician in the areas of internal medicine and psychiatry. Today's talk is to benefit physicians, providers, and educators, as well as patients on developments in sickle cell disease. So my topic for today is sickle cell disease and current medical treatments. Again, I'm Tamia Martin, and I'm a member of the Departments of Internal Medicine and Psychiatry here at the Medical University. I'm also the sickle cell disease program director for adults. So here I've listed some disclosures, and these are research-related disclosures. Today's objectives are to discuss progress in the management of adult patients with sickle cell and to overview novel treatments and curative therapies for sickle cell disease. So I'd like to start with a case just to give us a picture of a typical patient presentation and to bring you into what the management of sickle cell disease looks like. So this is a 32-year-old male with sickle beta thalassemia. His complications include avascular necrosis of his bilateral hips, recurrent PEs and DVTs on long-term anticoagulation, recurrent acute chest syndrome, and priapism. His medical comorbidities include depression and insomnia. He is currently prescribed OxyContin 100 milligrams PLQ 12 hours, oxycodone 45 milligrams, terbutaline, zolpidem, promethazine, and mirtazapine. In the year 2019, he had approximately 64 emergency department visits and 14 hospitalizations. Below you see his baseline lab count, including a slight elevation in his white count to 15.12, a hemoglobin of average 8.1, hematocrit of 20.8, an INR 1.14, an MCV of 75.2, and platelets of 530. His hemoglobin variant profile is as follows. His percent of hemoglobin S is 70.6%, hemoglobin F 22.4%, and his A2 at 2.7%. This patient enrolled in the adult sickle cell patient center medical home in 2015. He has a history of non-adherence to medications, which has been confirmed by his refill history and his insurance claims. He additionally presents to the acute pain clinic on an average of 2 to 3 days per week for pain management. Over the years, his treatment has been characterized by narcotic escalation following his recurrent hospitalizations and issues of tolerance. So we're going to come back and revisit that case after we talk about some of the therapies, but let's talk a little bit more about sickle cell and what we're actually treating when we think about treatments. So pain is the hallmark of this disease. It tends to affect hemoglobin homozygous SS disease and sickle beta thal 0 greater than SC and sickle beta plus thalassemia. Pain is the reason for the majority of our hospitalizations, accounting for up to 60 to 80% of our chief complaints. It has a significant financial impact, although it should be noted that the majority of patients actually treat their pain at home. So whenever we're looking at some of this data, it always tends to have a skewed perspective, and in most cases, a smaller proportion of patients are driving most of our utilization and data. When it comes to sickle cell disease, infections remain one of the leading causes of death, but there are also cases of fatal vaso-occlusive crises, acute chest syndrome, acute right-sided heart failure, drug overdoses, pregnancy complications, and transfusion reactions. Just a little bit about pathology when we think about treatment, and this will be important. So what we've known for a long time is about the process of sickling and the rigid polymerization that occurs in deoxygenated environments. And this was at one point thought to be the sole reason for sickle cell disease and its complications. We've learned more over the years, and this relates to actually accumulation and adhesion of sickled erythrocytes, obstructions of blood flow downstream, resulting in ischemia and infarctions. There's involvement of capillaries and post-capillary venules. A lot of inflammation occurs within these blood cells, involving release of multiple cytokines and chemicals. And there's an alteration involving the vascular endothelium and adhesive proteins in the plasma on white cells and platelets. And so it's not just the sickle cells alone that participate in this disease and its destruction. This is just a pictorial demonstration of what we see in sickle cell disease. At the top, you see the basic premise for the disease and this amino acid failure. And so what you have now is a regular hemoglobin S solution that polymerizes and then ultimately sickles and becomes rigid in a deoxygenated environment, causing downstream infarctions and occlusions. And this is just another pictorial demonstration of a normal red blood cell and what happens to a normal red blood cell in the case of sickle cell disease. So you go from this nice red plump cell that flows easily through blood vessels to now a sickle-shaped cell that causes a lot of destruction, as you can tell by the pointed ends. Just a word on sickle cell and fetal hemoglobin because it has important indications in therapy. So fetal hemoglobin is generally made in utero, and what normally happens is at birth, the beta globin chain starts to increase, and about 2 to 6 months, you start to see fetal hemoglobin decrease and fall off. Well, in a certain select group of patients, this fetal hemoglobin persists, and it's going to have positive implications for patients with sickle cell disease. And this is just the premise of treatment with hydroxyurea. So here's just a demonstration of bone marrow, blood, and vasculature before and after treatment with hydroxyurea. Essentially what it's showing is the role of fetal hemoglobin and how it decreases adhesion, decreases the overall percentage of sickle cells in the blood, and also therefore ultimately decreases infarctions and occlusion. So when we talk about interventions and treatment, sickle cell goes way back. It's the oldest known genetic disorder in the world, and it goes back to over a century. But for a long time, we didn't have many treatments described to help patients with sickle cell. Hydroxyurea first made some of its greatest impacts around 1967. There had been some study about it before then. And here at MUSC, we started statewide screening in South Carolina, not just at MUSC, under the direction of a group of individuals, including our very own Dr. Jackson in pediatric hematology, which had a great impact on screening, identifying these patients earlier and implementing earlier therapy, including penicillin, transcranial Dopplers, and we also had a greater use of blood transfusions, which can be life-saving, and in some cases, bone marrow transplants. But for a long time, this is all we had. So our patients solely are treated with opioids. And so when it comes to opioids, they're necessary. They're prescribed heavily. We don't have a lot of other options. So we must prescribe opioids despite some of the negative connotations associated with its use. So patients can be placed on opioid therapy as early as infancy and as early as infancy and during their years of toddler and adolescent years. And over time, its use seems to increase. Opioids work by binding the mu opioid receptor in the central nervous system. It then inhibits ascending pain pathways, and the release of dopamine is thought to be associated with the euphoria associated with opioid therapy. It alters the perception and pain response, but it can also depress the central nervous system. So we have opioids. It's the mainstay of treatment. Our patients can't really live without them. It improves their quality of life and their pain scores, but we're not really treating sickle cell. We're treating a symptom. We're not even treating it directly. It does not directly impact the sickle cell pathology. It actually changes the way we perceive pain. So that's not really the best treatment, but it is what we have. And there are good and strong reasons to prescribe opioids under careful consideration. However, long-term opioid use becomes challenging, especially in adult patients. There are not always adequate pain measures and ways to measure functional status across patients. There's the role of hyperanalgesia over time. And with recurrent crises and hospitalizations, most patients fall under a pattern of dose escalation. There are tremendous side effects that aren't always considered, including things like central nervous system depression and actually depressed mood as well, decreased libido, other things that we don't talk about probably enough with our patients. There's the risk of diversion and aberrant drug behaviors, and the use again increases with age. So we do and should always consider non-opioid management of sickle cell disease. So again, red blood cell transfusions can be life-saving, particularly in stroke patients and patients with evidence of organ damage. They should be widely utilized when needed, but they also have their complications, including iron overload and alloimmunization and transfusion reactions. There are bone marrow transplants, which are not readily available. Most patients will not have a suitable match, and there are risks associated even with this therapy, including death. Hydroxyurea, which is a very, very effective medication when taken appropriately in those who can tolerate it. The anti-inflammatory agents, neuropathic agents, and today what we want to highlight is some of our newer therapies, which include Endari, Oxbryta, and Adakveo. So again, some of our alternative therapies and multimodal therapies include NSAIDs, anticonvulsants, antidepressants, and topical agents such as lidocaine patches. There's the role of physical therapy, acupuncture, TENS units, application of cold and heat, and stretching. There's a psychobehavioral approach, which includes cognitive behavioral therapy, acceptance commitment therapy, as well as meditation, and in some cases, even procedural therapy, include nerve blocks, steroid injections, and trigger point injections when used appropriately in the correct patient. This again just kind of from a slide from the CDC, which highlights and underscores the role of some of the non-opioid medications, including acetaminophen and NSAIDs, gabapentin and pregabalin inside Neurontin and Lyrica, tricycle antidepressants, and our topical agents such as capsaicin and lidocaine and topical NSAIDs. And you can see there, they do go ahead to mention that these therapies can have a smaller benefit of opioids. So not a lot of patients are able to take non-narcotic management alone, but it should definitely be considered in conjunction with what they're requiring. And keeping in mind that pain is also treated by its pattern. When patients have acute painful episodes, they may be able to have sporadic prescriptions for opiates. And it's when you get into long-term chronic pain that patients are also on chronic opioids. So when you think about a teenager who has vaso-occlusive crisis, they may be treated inpatient with IV meds. They may not even have to go home on much oral. But this can be a short course, and they can go back to periods of non-opioid therapy. Unfortunately, what I deal with mostly in my practice are patients who have developed more chronic pain. Chronic pain develops usually around the early to mid-20s as patients approach 30. And at some point, patients who live long enough will probably all experience some kind of chronic daily pain from previous infarctions and sickle cell crises. And then that's when the role of chronic opioid therapy comes into play, including daily short-acting meds as well as a long-acting opioid. So this just kind of depicts some of the most common locations of pain in sickle cell disease, and this is what the patient's experience is. So it is sometimes challenging to get the patient to think beyond the pain, which is just the tip of the iceberg, because pain generally represents something. There's a reason for the pain. There's something going on inside of their body that's causing that pain. Lower back was found to be one of the most common locations, and unfortunately, we don't have a lot to do for lower back pain. When we develop things like avascular necrosis and joint pain, we can sometimes have surgeries. With back pain, sometimes they're successful injections, but it becomes a chronic daily source of pain because you can't replace the back. So it's not always about nerve compression. Sometimes it's just bony pain that's going up and down the spine, and it can be very debilitating. Some of the less common areas are noted there, including jaw pain, which I've seen quite a bit of. And we sometimes found patients actually have infarcts when you x-ray their skulls in their face, and found that to be the source of why their face is hurting so bad. So sickle cell can pretty much affect anything and anywhere, and we try to remind ourselves and patients of that. So again, there's the pain itself, but then there's actual complications. So what does that pain represent? As you can see here, almost every important system in the body is named as a source of a complication. So sickle cell, again, affects everything. You don't even see there, even dental. We have a lot of dental problems in our patient population. It's probably multifactorial, including chronic opioid therapy and the sickle cell disease, but it affects any and everything from the head to the toe. So just thinking about that pathology, again, now that we know a little bit more about what happens in sickle cell and that it's not just strictly sickling, we found out more about different compounds such as nitric oxide there. You can see at the bottom that are involved in the sickle cell process and inflammatory agents. The approach to treatment has changed, and it continues to change. So here we are, just showing the timeline. Way back in 1910, around that time, although there have been some other cases named throughout the country a little earlier, but in 1910, we'll say disease was first described. Hydroxyurea made its way into therapy around 1967. It's one of the first medications. And you just see time, where nothing's really happening. And then in 2014, the National Institute of Heart, Lung and Blood came up with a consensus set of guidelines, and even these guidelines, very useful, very thorough, are really based upon what they say a consensus of approval. There's not a lot of evidence-based medicine. It is an area of healthcare disparity with little research and little therapy. So it wasn't until the past few years, around 2017, where our new therapies became available. So again, there's the basic amino acid mutation, polymerization, dehydration of cells and blood vessels, inflammation, adhesion, and oxidative injury that we know occur throughout this complicated process of sickling. So this gave us many other areas to target for therapy, and I'm not going to read all of these, but we're going to talk about some of the medications that have come out based on these targets and things that are in development. And just going back, because I don't have slides about hydroxyurea, but our first therapy basically was a fetal hemoglobin inducer. And we talked about why that's important and why that works. And again, very, very effective for patients who are able to tolerate it and who are adherent. So the first of these agents that came out was Endari, which is a commercial grade of L-glutamine. So a simple amino acid was found to have significant impacts in sickle cell disease. This was around 2017. And so Endari, or L-glutamine, reduces acute complications of sickle cell disease and vaso-occlusive crisis, essentially. It is indicated for patients age 5 and older. The mechanism of action is not fully understood, but it's believed to restore the ratio of NADH to NAD and reduce oxidative stress. So free radicals and oxidative damage is known to be a big part of the inflammatory cascade. And this medication can be used with hydroxyurea. So that's one of the pluses to it. It was first studied in a group of 230 patients with sickle cell homozygous disease or sickle beta thalassemia over a 48-week period. It was shown to reduce episodes of vaso-occlusive crises by 25%. It also was shown to reduce the frequency of hospitalizations by 33%. There was 60% less occurrence of acute chest syndrome in the test subjects. And just note that this medication is available as a pharmaceutical grade powder in sachets of 5 grams. So that will be one of the things just to consider is that when you have a chronic illness, and I think sometimes we don't consider this enough, it can be very difficult and it can be very tiresome to always have to take medicine. But it is something that you have to mix up, and sometimes depending on your dose, more than one packet. And it does have to be taken with a certain amount of fluid or a certain amount of food. But for a patient who's a good candidate, it actually can be very promising. And it actually is one of the first things that you might want to consider when a patient is unable to tolerate hydroxyurea because it has such a similar effect. But some of the side effects that you can see include nausea, constipation, headaches, cough, abdominal pain, and actually pain in the extremities, back, and or chest. And what we do, we monitor for these side effects. We sometimes may have to reduce the dose if a patient's experiencing side effects. We may have to change the timing of the medication, maybe to nighttime. We may have to pre-medicate if it's something like nausea, treat constipation and things of that nature. But, we do what we can to make the medication, effective and something that they're able to use. So moving on, a year later, almost 2 years later, in 2019, along came 2 other therapies that we'll talk about. So there's Oxbryta or Voxelotor. So Oxbryta, which is become a very popular medication in our patient population, actually halts sickling and the destruction of red blood cells. And the other thing that you see with this is that it can actually increase the number, it can increase the actual value of hemoglobin. So, and this can be up to 2 grams. So in other words, a patient who, if they walk around with a baseline hemoglobin of 6, with good therapy, over time, you can get their baseline to increase to 8. And you won't see this in every patient, but in adherent patients, you will see an increase in their hemoglobin over time. It is an anti-polymerization molecule, and it decreases the hemoglobin's affinity for oxygen. It's indicated in patients aged 12 and older. It comes as a tablet, using 500 milligram tablets, and can be used with hydroxyurea. It should be noted that neither Endari or Oxbryta have been studied in pregnant women or breastfeeding women. So Oxbryta was studied in 274 subjects over 24 weeks in phase 3 trial. It was shown to raise hemoglobin to a mean of 9.8 in 51% of the patients, compared to 6% of placebo-treated patients. It lowered levels of reticulocytes by 19.9% and bilirubin to 29.1%. And this is important because these are well-known biomarkers of disease. Side effects are listed here, and it's kind of what you see with other common medications, the headaches, GI symptoms, but also you can see a rash with oxybrita, and you may have to change therapy if they develop a rash, either cease dosing or lower the dose. In some cases, you can even see fever. Contraindications to therapy include any hypersensitivity to voxelotor. There's no adjustment needed for mild to moderate or class A and B Child-Pugh disease for hepatic impairment, but in Child-Pugh C, which is severe hepatic impairment, the dose should be reduced to 1,000 milligrams from 1,500. There's no adjustment required for renal disease, and it should be avoided or adjusted rather with strong CYP3A4 inhibitors or inducers, meaning you may have to increase or reduce the dose. So lastly, of our agents that are gaining interest and are making a difference in our population is Adakveo. And I don't want it to do that. Let's see. So Adakveo is a monoclonal antibody, and the generic name for it is crizanlizumab. I'm learning to say that word. It is a P-selectin inhibitor, and so when you're talking about P-selectin, you're thinking about adhesion. So this is a molecule that will decrease the stickiness and the interactions between white cells, red cells, and the endothelium, and that's important in reducing sickling. It reduces pain crises by 45%. It reduces pain crises by 45% in trial subjects. It's indicated for patients age 16 and older. It has unknown safety profiles in pregnancy and breastfeeding. Now, this medication is an infusion, and it's administered over a 30-minute period. And first, you want to do this at weeks 0 and 2, but after which it's administered once a month. Patients are generally observed after their infusion for 30 minutes to an hour, and in general, it's pretty well tolerated. We have found in some of the post-marketing observations that it may be necessary to pre-medicate some patients who are receiving it, just as you would with a transfusion with Benadryl and Tylenol to decrease the risk of infusion reactions. It was studied in a sustained study design, which involved 198 patients over a 52-week period. It showed a reduction in frequency of vaso-occlusive crises, a reduction in the days hospitalized, and delayed time to the first vaso-occlusive crises. So one of the most serious side effects of this medication, crizanlizumab, is infusion reactions. Infusion reactions can be described by any of the characteristics on this slide, which include fever, chills or shivering, nausea and vomiting, excessive fatigue, dizziness, sweating, hives, itching, and shortness of breath. If a patient develops this during the infusion, the infusion should be stopped. And after the infusion, you may need to consider whether they're going to be able to continue with this therapy or whether pre-medication would be an option. Other side effects to this therapy include joint pain, fever, nausea, and back pain. So I just want to at least highlight some of the other exciting therapies going on in sickle cell disease, though a little bit beyond my scope of practice. But the Cure Sickle Cell Initiative was implemented in 2018 by the NHLBI. It is a collaborative research effort in order to accelerate the development of genetic therapies to cure sickle cell disease with a goal end of 5 to 10 years. It is meant to engage academic researchers, private sector researchers, and patients and their caregivers to develop strategy for cures. It's meant to determine the safest and most effective and most readily and widely adoptable genetic therapies and to move newly developed therapies into practice. So I'm sure most people here over the past few years have seen the excitement surrounding patients who are being cured now, moving away from bone marrow transplants to gene therapy and other modalities which seem to be potentially a little bit safer and providing good results. These patients aren't necessarily all considered to be cured as they continue to be monitored after their therapies, but there have been quite a few patients who've been able to participate in some of the trials with the National Institute of Health and are benefiting from this therapy. It's been groundbreaking. Watching the stories, it is amazing to see someone who was suffering from daily pain or from multiple crises to going on to live a normal life and now playing karate and swimming and things that they could never do before. So this is our hope for all of our patients. And going forward, the earlier these therapies occur and are implemented, the better. Once you develop the complications, you can't take back the stroke or the vascular necrosis or the kidney disease once it's happened. So the earlier the better, and it's going to take a lot of involvement. So hopefully the Cure Initiative plan will be really effectively and assertively used because one of our big issues is always payers and resources. So gene therapy, again, is becoming very, very, very popularized. At the bottom, you see there that they compare bone marrow transplants to gene therapy. And basically, with bone marrow transplants, you replace the bone marrow with a healthier bone marrow, someone else's bone marrow. In gene therapy, you modify the genetics in the bone marrow that you already have to create healthy, normal bone marrow. There's also some exciting things going on with CRISPR therapy. And again, we're not going to talk about this in detail, but just want you to know about this. And that's kind of like a DNA and RNA kind of splicing and reprogramming technique. And this here's just highlighting the fact that they have more and more trials now heading to research into implementation. So we hope to see more things coming out of the next couple of years. So in summary, going back to the case review, the one thing I wanted to highlight about that case was that if you look back, and I should have probably brought it back up, the patient was on multiple medications, but he wasn't on anything that was disease modifying. And I think that's something we have to really, really think about as providers. It happens to me a lot where the patient comes in and they're always going to be complaining of what's bothering them the most. So you get stuck on the pain and, we start talking about the medicines and adjusting the medicines and increasing them, but we never went back and said, like, why is this person on hydroxyurea? Why aren't they on some of these new things? So in order to avoid, one, this constant dose escalation of opioids, but also to provide them with the best treatment, I just want all providers to be really diligent in making sure that we're looking at and we're knowing what's out there for the patients now. They can be very expensive. Some of these medicines cost up to $40,000 a month, but with the physician assistant programs and the prior authorizations, we work very close with these companies. We can get it approved, and it will be of no cost to the patient. So we just have to be diligent about that, but we want all patients on good therapy. I want to highlight that hydroxyurea, despite everything, remains an important first-line therapy. It may be difficult to even get some of the other medicines approved if you haven't tried it. And again, it is a good therapy. But early, initiation of these novel agents should be considered instead of waiting until all the complications have occurred. So I'm trying to do some practice changing myself because, you get a lot of resistance. And you have to really educate patients on the importance of why we're doing what we're doing and the limitation of opioid therapy. And so we must become more familiar with the therapies to maximize treatment and outcomes in our patients with sickle cell anemia. This ends the presentation. A fire alarm threw me off. I was like, you can hit stop on it. Yeah. Oh, no, you're fine. No, you're fine. I see these ladies in here ain't scared of no fire. Y'all don't want to move. I don't think it will. Yeah, you had a nice gap. It was quiet. You're fine.